Um, Welcome everybody. We have an exciting presentation this morning. We have two speakers, Dr. Drew Ayars, coming to us today from Bellingham Allergy, Asthma, and Immunology, and Dr. Greg Davis coming from Proliance ENT. Both are also, I think, well known to most people in the audience, as they're also clinical associate professors here at the University of Washington. And they'll be doing Battle Royale surgery versus biologics for nasal polyposis. So, all right. All right. Okay.
Hey, good morning, everybody. Thanks for coming. You online, thanks for being there here. So Drew and I, we've known each other a very, very long time. I'm going to talk about that in a minute. Just some quick housekeeping. If I can get this to advance. There we go. I have a couple disclosures. Nothing that really kicks in related to this talk other than my disclosure. I'm a surgeon, and that gives bias. So keep that in mind. These are all of Dr. Ayers' disclosures. What's going on? You gotta get in the game. Okay, so it all started way back when we were like this tall at the UW, both assistant professors, and I do not really recall how we actually met, uh, other than it was probably a shared case and challenging cases, and Drew and I started having conversations probably by email, excuse me, and then might have grabbed a coffee at the coffee bar there at the UW. And then one thing led to another. And by the uh, kind of end of this, we were sharing clinic together at the university. And it was just this amazing collaboration. We would see some of the most challenging asthma, nasal polyp patients. Actually would see the patients kind of separately, and then we'd talk together, and then we'd go back and talk to the patient together. And it was just a truly remarkable experience. But then for various reasons, I left the university 5 years ago for this little practice down in Puyallup, Washington, which was 3 miles outside my non-compete. And I've stayed because I love it. My practice is amazing. I love my partners, my staff. I have my own nurse, my own medical assistant. Patients get called back the same day. It's pretty remarkable. We have a surgery center in our building as well, which is really convenient for patients and us. And then not too long after that, Dr. Ayers moved up north. He wanted to get closer to Mount Baker. And so he's in an amazing practice up in Bellingham. But we still communicate. And in fact, we're sharing a patient that is headed to my OR and starting in about 2.5 hours. So we continue to collaborate. And one of the points is this is a team approach. This isn't us versus you. And even though it's called Battle Royale, we may differ in some of our approaches, but really at the end of the day, it's teamwork. And so we're going to talk about that. We're going to talk about proper patient selection and evaluation for biologics. Again, this is all related to patients with nasal polyps, and asthma will come into play, but it's focused on all patients with nasal polyps plus asthma, usually. Which biologic to select, the debate of timing of the biologics is quite important. And then we'll talk and end with our team approach and give you some kind of critical key points of what to do and how to proceed with these challenging patients. So there's kind of like 7 different topics we're going to try to get through in an hour. We're probably not going to get to all of them, and so we may fast forward towards the end. But the first question was, if I diagnose a nasal polyp, should I prescribe a biologic? Right? And so a polyp walks into your office, what do you do? It kind of sounds like the opening of a joke, but we're going to start with Drew's response. And Drew, it's so nice to work with you. And Drew was also one of my guest speakers at a sinus surgery course a couple weeks ago, and just like the surgeons really appreciate what you do and how you speak. So thanks.
All right. So do I prescribe a biologic? Well, of course, it's medicine, it's for Trump surgery. So no, the answer is obviously you get more history. And, a lot of these patients, especially now, and we could get into this, most of the patients we're seeing now have had these polyps for years and years. So we're kind of hitting low-hanging fruit. A lot of them have had surgery, they've been on appropriate therapies for years, and now these biologics are available. But more and more, we're seeing these patients in clinic, and sometimes I can even diagnose some polyps in clinic if they're big enough. So, obviously, we have all these new toys. Why don't we play with them? We have you know, obviously the alarmins at TSLP, and there's new data. We're going to quickly go over on that. And obviously we have our Th2 pathway that we have multiple ways to block, obviously. We have the IL-4, IL-13 blockers, the eosinophil, anti-IL-5, the anti-IgE. So, you know, and all of these classes have a medication approved for nasal polyps. So we have all these different options. Now, you know, kind of how we go through these is, you know, you do have to obviously look through and understand the data and how these medications got approved and how efficacious they are. And I want to get through this quick because Greg has some great videos, and that's always the highlight. So we want to get to that at the end. But I want to quickly go through the landmark studies. I'm not going to spend much time on this, but all of these studies are kind of outlined the same. This one with Dupixent and the Lancet several years ago. And it's a combination of two studies, and a lot of the people or a lot of the companies are doing this right now, where basically they randomized to Dupixent or placebo. But we're going to bring this up later. A lot of you know that they did randomize the Dupi group after 6 months to continue to receive the injections every 2 weeks or to go to every 4 week regimen. And I think about that when I'm seeing patients in follow-up, especially. And the big endpoints are nasal polyp scores, and Greg's going to walk us through what he looks for when he's going through all of this. And I think that's really helpful also in understanding a lot of this data. So as you can see, most of the patients in these studies are pretty similar. This study is pretty comparable to all the other ones, other than the mepolizumab study, where you had to have a surgery previously to get into this. In this study, about 70% of the participants had a previous sinus surgery or more than one. Most of the patients in this study did have elevated peripheral eosinophils, and also to kind of cut to the chase, I usually see if they've had an eosinophil level off prednisone. And if it's elevated, I feel much better that these therapies are going to be helpful. And around 30% had AERD. So if you look at the data and how the nasal polyp scores dropped, and kind of remember these. I don't have a head-to-head slide, but with the Dupixent, it's around a 2-point drop. It was 1.8 and 2.06 in the two major studies. And as you can see, when they started to randomize to every 2 weeks or every 4 weeks, you can see that every 4 weeks and every two are fairly similar. They didn't see that uptick in the scores. So not only was it effective, but at every 4 weeks, it was almost as effective in a lot of these patients. The next big study is the omalizumab trial. Again, these are all set up very similar, looking at nasal polyp scores, congestion scores, and the two trials were polyp 1 and 2. So again, to kind of look through, if you remember the Dupixent, the nasal polyp score dropped around 2, whereas this was statistically significant. It was around 1, but it was effective in the study. And omalizumab got approved for this study as well. And then the mepolizumab is the final one. And same kind of study design, although in this one, they did choose people that had to have a previous sinus surgery. So it is a little different patient population. And similarly, they did show a significant decrease, but, you know, in the mepolizumab, it was about 0.73. And there's a meta-analysis. I'm not going to go through at the end, but it's a good one if you're interested to read through that kind of compares a lot of these studies. Obviously, it's hard to do, but it does give us some information. So, of course, medications and that stuff.
Well, yeah, I don't know, hundreds of thousands of dollars later, Dr. Ayers, they come in my office. Do I immediately prescribe a biologic? No. Why would I do that when the data shows that surgery helps patients? So I kind of rely back on the Euphoria study. We're going to talk about this on a few different slides coming up. I'm also going to recap some of the slides that Drew showed, because it's kind of how you interpret these studies is important as well. So back in 2019, when Euphoria came out, there was this dichotomy between history of sinus surgery versus no history of sinus surgery. If there was no history of sinus surgery, you needed more of these criteria that you can see down on the right, versus if there was a history of surgery, you needed fewer. Hey, come on in. And oh, front and center. Yeah, we won't pimp you. So what this kind of implies is that, well, if you have surgery, you're kind of one step forward. You're doing okay, but also you can think about it as if you've already had surgery, maybe there's fewer criteria you need to actually get into the biologic category, meaning you're kind of more severe. That's how I interpret it. And that was back in 2019, and then things changed with the update that was just a year or so ago. And this is the global summary. We're going to focus in on 2 points. The minority of patients, most of these in the minority, basically surgery is just not an option. Either they're too sick or they don't want surgery. But then there's this last category at the bottom of that yellow rectangle. You see early recurrence of polyps within 12 months of prior optimal sinus surgery. So if the polyps recur early after optimal sinus surgery, and we're going to talk about that later, then consider a biologic. And I totally agree with that. That's a minority. The majority of patients, if we look at them, these are patients with persistent recurrent disease after 12 months, despite thorough surgery and appropriate postoperative care. And this is where the euphoria doesn't really say do this or this or this. It says you can do any one of these 5 different things, from biologics to doing repeat sinus surgery, aspirin desensitization, steroid sinus implants, which is the Sinuva device, or consider a short burst of oral steroids. So it's nice because it gives you the options to decide what you want to do. So yeah, that's my answer. Do I do biologics right away? No. But going back, if I have a patient, I've done thorough sinus surgery, or one of my trusted colleagues has done thorough sinus surgery, and the polyps are coming back early, and they're maintaining good postoperative care with steroid irrigations, yes, then I go to a biologic. That's the answer that I get. So, topic 2, labs. I get serum labs on all my patients with nasal polyps because serum labs influence my decision on biologic selection. Don't we wish? So my answer, early in my career, yes. Now, not too often. So early in my career, I thought it was really important, and partially because of the Euphoria study, and specifically wanting to show that it was type 2 inflammation. I thought that made a difference in my decision to put someone on a biologic path. Euphoria then actually says, however, we acknowledge that we do not precisely know how to define type 2 inflammation in CRS with nasal polyps and to what extent biologics might be helpful in mixed inflammation. Therefore, it was decided not to make type 2 inflammation mandatory, and that's in the update. So you no longer have to prove type 2 inflammation, at least according to the Euphoria. When I see a severe polyp patient and it's bad asthma, occasionally I will often get IgE and a CBC to look at the eosinophil level. And partially it's just to tell the patient, look, this is a systemic disease. And it's not just taking out your polyps. That's just the tip of the iceberg. So that would be why I get labs. Drew, what's your answer?
In the beginning, I would endotype, and they in those guidelines they admit they used a lot of the asthma guidelines as far as the eosinophil cutoff, total IgE. So, and initially when Greg and I were doing this, they weren't approved for nasal polyps, but they were approved for asthma. We knew they worked, so we would get labs then a lot just to see if we can get them on a biologic that we were pretty sure would help. So if they have asthma, yes, I will get that. If I'm trying to figure out the best asthma therapy, obviously go along with that. But most of the people we see in clinic, I'm able to find a few old CBCs. I will look through eosinophils if they have significant allergic disease, say their flares happen certain times of the year. Yes, I'll get a total IgE. Obviously, see if they're allergic to anything environment, perennial air allergens. So on all my nasal polyp patients, no, I don't get labs routinely, but there's a fair amount that I do. And again, especially if there's asthma. And Greg and I talked about this recently on a case. CF is something, if it's happening younger, that I sometimes forget to screen for. So that's something to keep in mind. But I don't get labs for everyone with nasal polyps. But if they have any of these other comorbidities, often yes, I will. So this is the same kind of thing. And Greg and I kind of put our talks together independently and put them together. We had a lot of the same slides coming in, and this is kind of the same guidelines that basically use the same cutoff points. And they say uncontrolled despite appropriate medical treatment and appropriate sinus surgery and fulfill 3 of the 5. And a lot of our patients obviously have asthma. A lot of them have nausea, their quality of life is impacted. So I often will get eosinophils and IgE, especially if I'm on the fence about, not only prescribing a biologic, but which one to go through. So I use the same kind of thing, not word for word, but I use the same kind of idea when I'm going through these patients. If I think labs will be helpful, if they have asthma, I will check that. So not everyone, but Greg, I'm similar to you. I will check them in certain cases. When should I consider a referral to a specialist? I'm biased just from our collaboration and with everyone else at UW. So yes, I try and plug all of these patients in for a lot of reasons. One, and we'll talk about this at the end, our the way we go about it's very similar. If they haven't had a sinus surgery, I want to get them in to at least discuss it. And that's what I tell them. Some people say, gosh, I do not want surgery, but I still send them there to discuss because a lot of people, after they realize what it entails, they do go through with it. You know, I also like it to monitor response to biologics, especially if they're coming back quickly. I want to know that, getting a CT every few months is obviously not a lot harder. And then obviously a team approach. The biggest reason, if these patients call me on a Friday evening for something, I say, Greg probably has to get a look at you, so call him. Um, that's the main reason I get everyone established. But no, I almost all of these patients, unless they've been in and out of ENT offices and they've kind of been signed up, almost all of them I will have managed because like we talked about, we love our team approach. So
Very true. And our I think our job as clinicians is to give our patients options, and it's not the same as treating a patient with cancer where they're going to see the oncologist and the oncologic surgeon, but it's a similar team approach. We want to be able to give the patient both options, and they may agree on each other, they may disagree on each other, but ultimately it's the patient's decision, and we'll make a shared decision making with them. So I definitely think 100% if you see a patient with nasal polyps and they haven't seen an ENT, you should refer to ENT. And not just to consider surgery, but there are a lot of topical medications and topical therapies we can do. For whatever reason, ENT, tend to be the people who prescribe the topical steroid irrigations. I don't know why the other specialties don't or can't. Some do. Drew does now because he got tired of having to ask me to do it, or he does it now. But it's really easy to prescribe topical budesonide or topical mometasone through the compounding pharmacies, even topical antibiotics from time to time. And there are other devices. This isn't part of this talk, but these steroid releasing implants that we can place inside the nasal cavity, and that's a non-surgical option. It's something that can be done in the office. From an ENT perspective, we're super happy to involve anybody to handle the medical side of things. There are very, very few ENTs who touch on asthma, and I think that's appropriate. It should not be in the ENT realm. It should be with the allergists, pulmonologists, and primary care providers if they're savvy with that. Okay, the optimal time for a biologic. When is it? This is a big question. And my opinion is failure after appropriate complete sinus surgery and appropriate post-surgical topical treatments. Or if they're a non-surgical candidate, again, they could be non-surgical because they're too sick for surgery. They don't want surgery. Lots of different reasons. And I rely on this study by Alina Toscala, one of my good friends, and her team. This is interesting. 16 patients who were on a biologic prior to sinus surgery versus 16 patients who were the controls. And it's actually, this is a little incorrect. They were just on a biologic, no surgery. So surgery was performed 33 days after starting the biologic, and the follow-up was 12 months later. The follow-up, the main outcome measure was polyp size and SNOT-22 scores. So polyp size, just to digress a little bit, this is how we grade polyps. 0, there aren't any. 1, they're just these little tiny things up in called the middle meatus, right at the opening of So it's lateral to the middle turbinate where the frontal, anterior ethmoid, and maxillary sinuses converge and open up into that little space. And grade 1 polyps don't really block much. Grade 2 polyps start blocking things. At grade 3 is when they go below the level of the middle turbinate. And these are ones that if you have a headlight and a nasal speculum and the patient has a pretty straight septum, you're probably going to see the polyp. Grade 4, you're definitely going to see it. That's where they're almost coming out the nose. They're nearly completely obstructing the nasal cavity. So this is important because all these biologic studies kind of gear off of this scoring system, and it's a bilateral. So 0 through 4 on one side, 0 through 4 on the other side. Getting back to the study, in the group that had a biologic and surgery, the polyp score decreased from about 5 down to almost 0. And this is at 12 months versus the controls, people who just had the biologics, their polyp score decreased from 5.2 down to 3.8. So pretty significant difference between the two sides. The SNOT-22 scores in the biologic and surgery cohort decreased from 56 down to 29, and a clinical mean important difference is 8.9. So definitely a meaningful difference versus the biologics only decreased from 58 down to 48. Still a clinical important difference in change in the SNOT-22 score, but not as much. And it's kind of, I mean, it's a little bit of a captain obvious. Like you go in and you suck out to breed all these polyps, you'd expect the polyp score to go down quite a bit. So that doesn't surprise me a whole lot. But I think what surprised me a little bit more was the improvement in SNOT-22 scores, how much better it was in the surgical cohort. A different study by McLani, and this is important, and one of our good friends, Rod Slosher, who was also at this course a couple weeks ago. This is a multi-center study, 111 patients with nasal polyps. They compared the kind of the key published phase 3 trials for Dupi, omalizumab, and mepolizumab. No difference in the baseline severity scores. And at 24 weeks, sinus surgery was superior for improved SNOT-22 score in one of the two Dupi trials and both of the omalizumab trials. Sinus surgery was superior to all the biologics for lower polyp score. Again, it kind of makes sense. And sinus surgery was comparable to the biologics for smell testing. So yeah, your sense of smell gets better if you use a biologic or if you have sinus surgery, and that's pretty equivalent. At 52 weeks, sinus surgery was, so ESS is endoscopic sinus surgery. Sorry, I didn't define that. Endoscopic sinus surgery was similar in the SNOT-22 scores with the dupilumab versus surgery, and sinus surgery was superior for decrease in polyp size. So long-term success is about the same between surgery versus Dupi for the SNOT-22. So I don't know if that answers my question. When do we use? I'll tell you what my answer is now after looking at the data. If I have a patient with polyps who comes into my office and they're already on a biologic, it's not guaranteed, but it's almost always a home run that if I do sinus surgery and they're already on a biologic, they're going to do really, really well. Like it's relatively easy to get a good result. Now, there are some patients who are resistant for whatever reason, and resistance isn't the right word. They don't respond to the biologic, and that's a challenge that we're going to talk about in a bit. But I love it when they come in on a biologic. It's like, oh, this is going to be easy. It's cakewalk for the patient. But, you know, do they have to be on a biologic ahead of time and go through that expense? No, they don't, because a lot of times they get better, as these studies show, without a biologic. True.
I have kind of the same response. You know, when I talk to them about surgery, you know, obviously how many have you had? And one of the things I always ask is how quickly did the polyps come back after surgery? You can get a pretty good sense, right, Greg, of how severe the disease is, how quickly they come back, the polyps after surgery.
Like 3 months. Yeah.
Yeah, so I remember you calling saying this one looks bad at 3 months. I think we're gonna need a biologic. So yeah, no, I always ask, have you had appropriate sinus surgery? And sometimes I'll run it by these guys and see what they think on imaging. And I also say and talk to Greg about this. Part of the reason for surgery is to deliver medication up there. And you know, if they had surgery but they were doing Flonase for a few weeks afterwards, didn't really give it a try. You know, they didn't do much. You know, much more apt to send them back, see if another surgery, is indicated. Whether, they've done the steroid rinses, I'll often try that as well. But yes, if they've had appropriate sinus surgery and medical therapy, I'm more apt to go on to medical therapy as well. But I usually will touch base with Greg or the ENT physician and get their thoughts as well. So, yeah.
If you have somebody in your church who's like, who decided we probably would benefit from surgery, but they maybe have like comorbidities or for whatever reason decided we also benefit from biologics. Do you have a preference whether they start before or they start after surgery?
Yes, we need to so the question, yeah, from the audience was basically if someone is, we know they're going to be on a biologic because of comorbidities. Let's just say their asthma is not well controlled on their standard therapy. Would I prefer if they're on the biologic before surgery or after surgery? And yes, before. It's nice, and the research supports that as well. Doing it, usually when someone starts a biologic, we see a pretty significant, rapid improvement in their smell function and their asthma function within sometimes the first week. But it tends to take a couple months for the polyp size to start shrinking if it's going to respond. I like, if they can be on it a month before surgery, that would be my preference.
Really similar question right here. I have patients that say, no, I'm never doing surgery. I had a friend that did it. Everyone has a story, but I would often send them to you just for discussion. How often do you find that sitting down and going through the procedure, are they amenable to that?
Yeah, it's a patient who have been on Google or YouTube, or they've had a friend who had sinus surgery and they had a bad experience, and it happens. Sinus surgery has changed dramatically in the last 20 years. Remember, sinus surgery was invented in 1985, not that long ago. And so in the first 15 years of sinus surgery, up to 2000, it was kind of the dark days of sinus surgery. Lots of complications. Most surgeons were packing the nose with 6 feet of ribbon gauze afterwards, and these horrible experiences of pulling the gauze afterwards and letting the patient hemorrhage. Most of us who subspecialize, that's not the case anymore. The average pain level, we measured this in 60 patients. The average pain level after sinus surgery in our patients is a 3 out of 10. It's not bad. Most people take 3 or 4 days off of work, not several weeks. But there's always these stories patients hear. So sometimes I have to literally just sit down in the chair and talk them through what the average patient experience is. It's not a bloodbath, or it shouldn't be a bloodbath. Again, there's different techniques for sure. And, I do probably 80% of my surgeries are revision surgeries. And so it's a lot of kind of talking patients off the edge of, well, what's going to be different with this surgery versus the one I had before? And that's a tough conversation because you don't want to throw your colleagues under the bus and say, well, I didn't really do anything other than poke some holes. But sometimes that's a reality. And we're going to talk about completeness of surgery in a minute.
So, should I consider extending the intervals or injections? And Greg and I kind of had the same thoughts on this, and this is how we've done it as well. At least for Dupixent, which again, a lot of our patients are on. I go back to this study again where they randomized, and at 6 months, half the group went to every 4 weeks, and the other half stayed at every 2 weeks. And again, if you look at the data down here, when they split off, there's not a huge difference. Some people, in my experience, because I do this a fair amount, I spread it out. Most people actually took just as well. I have a few that say, gosh, I get out to 3 weeks, I'm miserable, I'm going back to 2 weeks. But especially if they don't have severe asthma on the side, I will try spacing it out if they've been stable on the medication for a while. I usually give it at least 6 months to a year, make sure they're happy on the therapy. But most people are excited to try, spacing it out to try and get on less medications. Although most people, love the medications and want to stay on it. And these are the patients that we've seen who've had sinus surgery and tried other things first. So I will, especially with the dupilumab at 6 months, 12 months, if they're doing well, I will try spacing out their injections.
I like to give the tissue 12 months of being in a happy state. So when I look endoscopically, if it's always about the trajectory, are they getting better, staying the same, or getting worse? And if the tissue calms down and it's not inflamed, it's not edematous, there's not polypoid tissue, if it's looking like normal tissue for 12 months, that's when I consider decreasing their frequency. And going back to the study that Drew just showed, yeah, there's very little divergent here when you go on the Dupy group from 2 weeks to Q4 weeks. The challenge is always how to prescribe it. And I've made the mistake more than once about changing the prescription to every 4th week, and then the insurance company denies it because that's not how it's supposed to be prescribed. And so now, I don't know. I think the patients, they just stock up on it for, there's a bunch in their refrigerator. Yeah. So that's, yeah, maybe we talk about that off recording. Okay. Yeah, that says the same thing. Okay, so the novel biologic, the new one's coming down the pike. Am I excited about the newer biologics? I think I'm going to talk about one, and Drew's going to talk about another one a little bit. So yeah, so we got depemokimab coming out. They published the Anchor 1 and Anchor 2 trials. It was a 52-week trial. The co-primary endpoints were polyp size, and we talked about that, 0 to 8, and then nasal obstruction, which is basically a visual analog scale, 0 to 3. So the polyp size decreased on a 0 to 8 scale on the Anchor study by just under 1, and the Anchor 2 about a 0.5 point. That's think about those polyps and like 1 point difference. Okay, it's not much. Nasal obstruction improved a little bit. Now these were, hey, statistically significant findings. Right on. Yeah, this is great. Right now we got FDA indication, but is it minimally important? Is there a clinical important difference between these? Doesn't make a difference in the patients. And again, I'm biasing this part of the talk because it's focusing on polyp size, not the big benefits of smell improvement and asthma improvement. But this is an in-office polypectomy. The right on your left is the patient's right side. The right is the patient's left side. That's just how we look at patients. And I'm just using a microdebrider. This patient's wide awake in my clinic after numbing them up. And I use a numbing gel called tetracaine. It sits there for 15 minutes. They don't feel very much, but I can, within 20 minutes, take the polyp size from a 8 out of 8 down to about a 1 or 2 out of 8. And the cost of an in-office polypectomy ranges between $1,000 and $2,000. So from a cost-effective standpoint, how do you compare that to the cost of a biologic? And what if I end up doing this once a year for the patient? Now, not every patient can tolerate this. Having an endoscope in their nose and a microdebrider that's going and sucking up the polyps, it takes a special person, but it's not that hard. So it takes me about, again, 15 minutes to numb up the nose, and then doing bilateral will take anywhere from probably 15 to 20 minutes. So it's pretty quick. This is in the setting that they have had good, thorough surgery before, meaning, I might as well talk about it now. Thorough surgery is taking out all the little bony partitions between the sinuses. So think about like this building. It's a big building with the structural walls are on the outside. There's probably a couple structural pillars in the middle, but we want to remove all these walls that make these little compartments. And that's what we do in the sinuses. We want to take out all the little partitions, these eggshell thin bones, so that it's one nice open floor plan. The main reason, there's 2 reasons. Number one, if there's less surface area, there's less tissue to create a polyp in the first place. If it's not there, it's not going to make a polyp. Number 2, we want to facilitate topical therapies, either by steroid irrigations or the exhalation delivery system, the Xhance. And that's why we do sinus surgery, not to cure polyps, but to decrease the surface area and to open it up. So if someone has already had thorough sinus surgery, and I'm not going in and removing bone in the office, which is harder to do, I can go in with a debrider and just suck out those polyps, chop them right up, and it's pretty easy. So when I look at these studies that show less than 1 out of 8 improvement in decreasing polyp size, I don't get excited about that. But if it's improving their polyps and it's improving their asthma, which I think Drew's going to talk about, and they can decrease their injections every 6 months, yeah, that's pretty cool.
So, yeah, I think a lot of us saw this data dropped recently, I think, right around the quad AI, the tezepelumab. And I was just able to get a copy of the manuscript just recently. So I didn't go through it with a fine tip comb, but I picked out the major points to the trial. Again, rather large trial, and it did lead to a significant reduction in the nasal polyp score. And as you can see, if you remember going back, the Dupixent the studies, they dropped nasal polyps. You know, kind of what that means on a clinical level. But this too is right up there with the Dupixent, where again the omalizumab was 1, the mepolizumab was around 0.7. That doesn't tell all the story, obviously, but as far as the total polyp scores, they did go down significantly, and it is a nice drop compared to some of the other biologics. So, you know, in the future, we may have another instrument, another weapon we can use. And overall, the data looks pretty good proof initially. So,
and I do see there's some chat questions. We'll just hit those at the end. We'll have time for Q&A. I'm going to go back to Drew's this study, and as a paper reviewer for several journals, when I see the change from baseline, and they have this scale -3 to 1, that's not even like this should be -8 to +8. And you see, wow, look at this huge difference. But if you put that on a -8 to +8 scale on the y-axis, it would, you know, those lines would be very close together. So it's kind of a little bit of reporting bias in how they're making the graphs. And again, is a 1-point difference in the polyp size very exciting? So 1 point on both sides, 1 + 1 = 2. That's why I said 1. No, not for me. But if it's helping the asthma and it's improving compliance, then yes, that's a good thing. Okay. I can't read that either. Let's see. So I forget what the question is. Something like biologics don't work. Now what? So it is real case. 48-year-old male, asthma exacerbated respiratory disease, moderate allergic rhinitis, grade 3 out of 4 polyps on both sides, prior limited sinus surgery. So looking in the nose, this is on the left side, that thing right in the middle, that's the middle turbinate. There's some polyps back there in front of the sphenoid recess. And this is on the left side. There's a bunch of polyps and hypereosinophilic mucin down there. So I'm going to go in the office, and this is not as savvy as the case from before, but I'm just going to pluck out this polyp in the left frontal recess. So this is right where the frontal sinus opens up into the nasal cavity on the left side, and just popping out that. So all right, hey, that's a 1-point improvement in polyp score. So we're paying attention. Okay, and that's what they looked like afterwards. That was pretty good. But then they came back, and the text isn't showing up, but they came back a couple years, or like a year. Sorry, I'm going to go back to here. So, yay, looks great. This is literally 12 months after that in-office polypectomy, and they're on a biologic. And then when I go to, then this, they came back 3 years later, and that's what they look like. They're still on their biologic, and the polyps came back with a vengeance. How do we get rid of that? So what do? I make sure they're compliant with the biologics. I make sure that they're compliant with their topical therapies. And that's, you know, just like everything in life, when people are feeling good, they stop doing what they ought to for maintenance. And it's kind of like, you know, taking an antihypertensive to fix the silent killer of hypertension. It's the same thing. It's like, I know you don't feel it, you're feeling good, but this is the time to be aggressive with your steroid treatment. You got to get steroids up your nose on a daily basis. You have to get steroids up your nose on a daily basis. I tell them that so many times. It's frustrating, but I get it. Irrigating is a pain in the neck. using the exhaled delivery system, Xhance, that's a nice option. It's just really hard to get it covered by commercial insurance, and it's never covered by government insurance. And it's really expensive. I always use mometasone now. So we started with budesonide back in about 2012 because it was off the pharmacy shelf, right? You guys used it for asthma, for nebulizers, and the group at Penn started to use it for saline irrigations, and they had a huge improvement. As time went on, we realized that mometasone, which is the active drug in Nasonex, is more lipophilic. It sticks to the sinus mucosa much better than budesonide, which is hydrophilic. It sticks to water. So that's why the sinus implants like Sinuva or Propel, these implants we put in the sinuses after surgery sometimes, they're coated with mometasone. It's just a better steroid for the sinuses. But you can't get mometasone from a normal pharmacy off the shelf. They don't make little vials of mometasone. So we use a compounding pharmacy, and pretty much all the compounding pharmacies now will make mometasone irrigations because they realize that's kind of the way to go now. And the nice thing is it comes pre-mixed with the salt in a little paper packet. So you don't have to add two things together. Cost is cheaper. Yeah, if they buy a 3-month supply, it's cheaper than buying the budesonide. Plus, budesonide can be in short supply sometimes. Like last year, it was a little bit hard to get. If they have allergies, I make sure they're compliant with their allergy management. And then I assess the completeness of surgery. All right, so this finally, like we always talked about in our academic high towers and subspecialty high towers about, you didn't do good enough sinus surgery, Well, we never had any data to show that made a difference. Our friends at Penn, they finally looked at this, and I'm not going to get too much into the weeds of it, but basically they scored patients who came in for revision sinus surgery, who had nasal polyps, on how complete their sinus surgery was. Did they remove all the ethmoid partitions, the ethmoid frontal partitions? Did they open up all the sinuses? From a scoring of not very much to, yeah, they did a really good surgery. And it made a difference. So in the patients over here, the patients in the blue outline, these patients did not have very complete sinus surgery when they came into Penn to have the revision surgery. But after surgery, 12 months later, those patients had a huge improvement in their SNOT-22 scores. Compared to the patients who came into Penn who did have fairly complete sinus surgery before, that's this cohort, their improvement wasn't as much. And what this shows is if you haven't had very complete sinus surgery, there's more room for improvement. So yeah, revision surgery in those patients can make a big difference. Versus if you've had complete sinus surgery already, yeah, you're going to get better, but not as much improvement. And then the final thing is just consider revision sinus surgery. And again, all surgery is not the same. All surgeons are not the same. There's a lot of really good surgeons around in the Pacific Northwest. And the 3 guys at the UW are fantastic. I like working with them and collaborating with them. There's Craig Miller at Virginia Mason's outstanding. And there's, again, there's several that are out there. But what you can do to figure out is the surgeon you're working with doing adequate surgery is just look at the CT scan. And I probably should have added a couple pictures. Are the little bony partitions in the ethmoids, are they all gone? And you can tell that pretty quickly because bone's white. And if there's a lot of little pockets that are still there, that was not complete sinus surgery. And so maybe that patient should see a different surgeon. And yeah, it's a little bit, it shouldn't be more risky getting the little sinuses next to the skull base or next to the orbit, but a lot of comprehensive ENTs or general ENTs don't feel comfortable opening up those sinuses. And that's okay, because I don't feel comfortable doing throat or ear surgery. There's no way I would do that these days. So everybody has their specialty. As Drew said, surgery in these patients, it's not just to take out the polyps. It allows us to more easily take deep sinus cultures. If there's pus coming out of a sinus, there's zero utility in just swabbing the nose, so there's no reason to ever do that. It does facilitate in-office debridement. So if someone has a really horribly infected maxillary sinus and I make a nice big opening, even if it stays infected, I can get in there in clinic very easily and just scoop out and flush out the debris that's in there. And most importantly, it allows the topical medications like the steroid rinses to get in and keep the inflammation under control. And that's key. If the several research studies show in cadaver heads that if you irrigate a head that has not had sinus surgery, almost none of the fluid gets into the sinus. So why do we irrigate in patients who haven't had surgery? Because it still bathes the nose and it's safe and you might as well do it. But it does really make a big difference in just improving that topical delivery. You have something to say here? I forget what it is.
I do too. Yeah. Gonna be good though, I'm sure. Oh, yeah, this is kind of a separate subject. I kind of just threw in at the end. There's a meta-analysis, Cochrane, from a few years ago that I read through, just comparing all the different biologics. And I think you can tell Greg and I have a kind of a similar way we go with this. I'm getting in with the ENT, see what options we have, their surgery, whether they want to try surgery with adequate medical therapy first. Then that's when I'll typically, Greg will call, say the polyps are back. I think this is a good biologic candidate, or they're on it already. And, we'll try the sinus surgery first, the biologic first. But, there's obviously multiple options. And I don't have one that I automatically go to with nasal polyps. Obviously, if there's an asthma component, I go along those lines. And if there's a strong allergic component, or if their eosinophils are through the roof. Greg and I had a hypereosinophilic syndrome patient, really severe guy, that he was part of a compassionate use mepolizumab trial. And I remember not only does asthma improve, but his polyps really melted. That was an HES patient, so it's a different kind of patient population. But if it gets to the point where we're trying biologics, and obviously this doesn't include any of the pentatolamab data, but if you were interested, this is kind of a nice review, a Cochrane review on the data, and it's obviously hard to compare, but they do go and look at, what's better quality of life, symptom scores, smell, and, say, based on the data here, what's the most effective for each of these. So obviously I'll choose the initial biologic, but, sometimes we'll switch it around if they don't have an adequate response. And a lot of times, again, that does take discussion with the surgeon. And that's another question. Do you get pathology on all of these folks? Do you send that off?
Yeah, I do send a polyp off, and I'm lucky to get a eosinophil count. It's if it looks like just a normal juicy polyp, I probably won't, but there's other things that kind of look like polyps that it's nice to get that off. But I do like to get an eosinophil per count per high power field. Well, this is kind of yours. Yeah,
You signed off on it.
I did sign off on it,
All right.
but Drew came up with it. And he's
No, this is kind of how I have gone about, if I see a nasal polyp. And again, this was easier years ago because the patients we were seeing for polyps have been in and out of clinics. Our clinic, they've seen us yearly. We said, here's what we have. And then the biologics came around, and most of these patients have had several surgery. We've been working on them a lot of other ways. So if there's a new polyp diagnosis and they've had sinus surgery, or I've talked to the ENT doc, they say, the polyps came back. Sometimes I'll go to biologics, but that's rare. So the first thing I do, if it's a new diagnosis, or if I can pick it out, if it's grade 4 or potentially grade 3, I will obviously get a history. Sometimes I'll do a CT, but I will get them plugged in with surgery. I would talk to them about options before the referral, but most of the time, even if they say surgery, not something I'm considering, I do get them plugged in for the reasons we discussed. So if they haven't had a sinus surgery, I'll refer them for the discussion. If they've had the sinus surgery, I always look to see whether they've been on adequate medical therapy. Some of these people say, oh yeah, I was on Flonase for a month afterwards, but I haven't tried anything since. And that's not, why we do the surgery. Yeah, so if they've had surgery, things have come back. Yes, I consider a biologic. Obviously the comorbidities come into play, their asthma. A patient last week who had aspirin desensitization before a lot of these biologics came around, and she's still doing great on it. She accidentally came off of it a few months ago. Things worsened. We put her back on, and she's doing really well. So I do consider asthma desensitization if there's a strong history and the patient's motivated. But as Drew brought up last week in his session, that we are doing a lot less asthma desensitization, but it's still an option. And the biologics, the choice. And there's a lot that goes into that. That's a separate talk. I do look at, the meta-analyses, kind of go head to head, and every patient's different. I do want to stress that. But, the choice of biologics, going to be, something I think we'll get more information on in the future. But based on the current data, I kind of have an algorithm I go through. And, if they failed one, I will try another. So, Greg, you want to?
All right. So in summary, surgery plus biologics offers a significant reduction in polyp size compared to biologics alone. Reduction in polyp size results in improved delivery of our steroid sinus irrigations. And that's key to my heart and our patients getting better. And then consider holding off on biologics until after surgery for appropriate and complete sinus surgery, unless the patient really needs it for their comorbidities, like their severe asthma. I'd much rather have that patient's asthma better controlled before I take them to the operating room and put them under a general anesthesia. You can't see the word of the day. Sorry. I think it's oh, it's nasal. All right, there. Now I'm gonna cover it up. If you're not paying attention, oh, there's one more look at it. All right. Let's take a look at the chat. We can. Okay. Oh yeah. Well, hopefully we repeated that question. For slow release steroid implants, how frequently is that performed? How successful is it? And are there studies comparing this treatment to biologics? All right, the steroid implants, really there's two. There's Propel, which lasts for about 1 month, and it's coated with mometasone. It's an absorbable implant. And there is Sinuva. It's coated with mometasone. It lasts for 3 months. Both are now owned by MedTronic. I am a consultant for their advisory board, but the research, I wasn't part of the research studies. It works. It helps decrease polyp size, improve congestion scores, improve smell function. There's a handful of patients where I do that probably twice a year, and they love it. It keeps them out of the operating room. 2 of those 4 or 5 patients are really sick, really bad coronary artery stenosis, and I don't want to put them under a general anesthesia just for some polyps. And so this is a nice non-surgical way. I numb up the nose in clinic. That takes 5 minutes, and then placing this device takes about another 5 minutes per side. It's pretty easy as long as they have a straight septum. If the septum's deviated, it doesn't work. The device is too big to get in the nose comfortably. Any questions from the audience for either Drew or I? I'm going to have Drew come up to the microphone. So the question in the audience online is basically how far can you space out the biologic dosing interval?
I don't space them out beyond 4 weeks. I have patients that do that. You and I may share one of those. I think I know who you're talking about. It will only do it every few months. She says she's a lot better. Her asthma exacerbations have not been as severe. And each time I say, I don't know how much this is working given how infrequently you're doing it, but I usually won't go beyond 4 weeks. Most of the patients don't want to either. And there's some of them that go to every, 3 to 4 weeks and say, gosh, I just don't feel as good. So at least we keep them there. And at least I can say I tried, we tried to decrease the amount of medication they need. But yeah, we don't go beyond 4 weeks. Some of our patients have, and we don't have a lot of those cases, but you probably have a lot of
And I'm just so happy that I know that he does now. I sat my steroids and said, if the next week I'm going to be like, if you have every day, and you can do that. You try those on the students then, or what do you do about that?
There's some evidence from the company that says there's a higher chance that the patient will be denied their refills their for Dupixent if they're not using a topical steroid. And so even if they're not going to do a steroid irrigation, at least have them on a nasal steroid spray. Knowing that none of that nasal steroid spray penetrates into the sinus cavities, but it's better than nothing. And that's what I'll tell my patients as well. I get it. If you're not going to irrigate, fine, at least use a nasal steroid spray. Twice, and you can go twice a day. If they're going to travel and they're on vacation, they don't want to do the irrigations, fine, do a nasal steroid spray twice a day. Yeah. The question is, after sinus surgery, if they're doing okay, is it okay for the patient to stop doing their steroid irrigations? And I have this conversation at least every other week with my patients. They're looking great. And I tell them, yeah, you can probably stop, or you can go down to every other day. We don't have any research that shows us how long patients should continue. But there's always that N of one study. The patient I operated, and Drew and I shared this at UW, was a patient of ours in 2016. I left the UW at December 31st, 2019. I saw him in early December, polyp-free. He was not on a biologic. He was polyp-free for 3 years. He looked great. And then COVID hit. He decided to stop doing the irrigations. He came back about a year ago and had grade 3 out of 4 polyps on both sides. So even after 3 years of having very well-controlled nasal tissue, his polyps came back. And so I don't know the right answer. I tell my patients that story. I'm like, yeah, you can go off it, but they might come back. They might come back when you're on it too. So I really don't know. But if they're going to choose to go off, I tell all of them, hey, if you get an allergy flare, or there's forest fire smoke, or you get an upper respiratory infection, you start to feel a little bit of congestion, please go back on your steroid irrigations twice a day. There was a question for those who want to use Mepo prior to surgery. Do you have any issues getting it approved? And I don't prescribe it prior to surgery. So Drew, do you want to address that?
No, I can't remember if I've tried to do this other than our patient with hypereosinophilic syndrome, because he was on Mepo, and I think he did clear him out, and that's. But no, I have a lot of experience doing Mepo prior to surgery. Obviously, our patients with asthma. But no, it's my first. I'll document that we're at least considering sinus surgery, but I don't know if I've run into that situation. I do more dupilumab, and it's often hard to get the tooth hard to sinus surgery, especially if they need another surgery, and we're putting them on biologics, so we can have them on it for the surgery. But no, I have done that a lot. I see another question I've been. I take on omalizumab and CRS without asthma. It's a good question, and the omalizumab data is not bad, at least comparatively to some of the other studies. So I will use Zolver, especially if there's a big seasonal component that have a significantly elevated IgE. Listening symptoms usually happen around, death by the winter or the pollen season. So for that. So sometimes I will use omalizumab. A lot of the times I'll start with this. If you kill them, I will usually start with dupilumab, but that is another good option, especially if patients with symptoms. So
there was a question I forgot to answer. It was, what's the dose of the mometasone and saline irrigations? And I honestly don't remember. My nurse checks a box when I write mometasone on the bottom of a sheet. But I get through Cascade Specialty Pharmacy, and every compounding pharmacy that does it, they're going to know what the normal dose is. And last question, have I had any ophthalmologic side effects from steroid rinses? No. So the research studies show that it does not increase intraocular pressures that you would be concerned about if you're using a nasal steroid spray. That said, if someone has glaucoma, high pressures, I'm not going to use this. I'm going to be less likely to use a steroid irrigation, but the research suggests that only 3% of the drug gets absorbed systemically. So it's really, really low. It's supposed to be lower than the nasal corticosteroid sprays. All right. So for those of you online, thanks for being there and appreciate your time. We're at 8 o'clock. Kevin.